Thank you very much. Thank you very much for the kind introduction, and I'd like to thank the organizers for the invitation for me to speak about highly pathogenic avian influenza A H5N1. This next slide shows my disclosures. And I'd like to start off with a case report. This was a really important case report that was published last year in December in the New England Journal of Medicine of a critical illness in an adolescent with influenza A H5N1 infection. So on November 4th of last year, this 13-year-old girl with a history of asthma, BMI of 35, presented with a 2-day history of conjunctivitis and a 1-day history of fever. She also had cough, vomiting, diarrhea, then developed respiratory distress and hemodynamic instability. She progressed, unfortunately, to respiratory failure, pneumonia in the left lower lung lobe, acute kidney injury, and thrombocytopenia and leukopenia. So this slide shows a chest x-ray. This is on her day of admission, showing primarily the left-sided pneumonia. And 1 day afterwards, huge progression. You could see here complete bilateral opacification of both lung fields after they had started ECMO. So just demonstrating the severity that could happen with this infection in people. And what they did is they started treatment with antivirals. They started with oseltamivir at a dose of 75 milligrams used per NG tube twice daily. They increased it as she progressed on November 9th to 150 milligrams. And as she was progressing, they also added amantadine at 100 milligrams per NG tube twice daily. And for good measure, they also included baloxavir on November 11th at 80 milligrams. So they basically treated her with maximum antiviral therapy. This slide shows the results of RT-PCR testing from the tracheal aspirates from November 12th to 28. And so with RT-PCR testing, with the cycle threshold, the CT value is very low. It means there's a very high viral load. So you could see here the viral load was 17.6 on November 12th, and it took roughly over 10 days or so for it to basically reach a point where the viral load was diminished, and there was no evidence of any resistance. So a very severe infection, very high viral load that persisted despite a cocktail of antivirals that were used for therapy. So to step back a bit, it's good that for everybody to have the same appreciation about influenza. So this is a diagram, a figure of an influenza virus. So in humans, there are two types of influenza that infect people, influenza A and influenza B. Since the pandemic, there's only been, there used to be 2 lineages of B, now there's only one, and it's B Victoria. B Yamagata has just disappeared. So when we're talking about pandemics, it's influenza A that we're talking about. And in humans, when we're talking about seasonal influenza, the strains are H3N2 and H1N1. And if you look at the figure, H is a hemagglutinin, it's a glycoprotein on the surface of the virus, and it really attaches to sialic acid receptors for seasonal influenza in the upper respiratory airway. The neuraminidase in red is an enzyme that basically cleaves virions that are attached to sialic acid, and it allows those virions to go and infect other cells. So the way influenza viruses are characterized are by these two glycoproteins, the hemagglutinin and the neuraminidase. And it's also important to appreciate the fact that influenza viruses have a segmented genome. So you could see in the middle, there are 8 strands of RNA. And that's really important because one of the ways that pandemics arise is by reassortment, so gene swapping, in other words. So it's important also to appreciate that influenza A virus is extraordinarily diverse, and it really varies. The types of hemagglutinins and neuraminidase varies depending on the species. So if you look at wild birds, there are hemagglutinins that are labeled as H1 to H16, neuraminidase from N1 to N9, and for all these animal groups, they can be infected with influenza, and the distribution will change. And to get an overall appreciation for pandemics, because this is one possible concern with highly pathogenic H5N1, is the sort of history of pandemics and for influenza A viruses. And the way pandemics are going to be or can be established is either this gene swapping approach with reassortment, or basically a direct adaptation of the virus to people. Okay, so if we look at H1N1, the Spanish flu 1918, this was direct adaptation of a bird virus. In contrast, if we look at the Asian flu in 1957, or the H3N2 Hong Kong flu in 1968, these were bird-human reassortments. H1N1 was reemergence of an H1N1, the Russian flu. And in 2009, H1N1 was a reassortment of genes from birds, pigs, and humans together. So we don't know yet whether H5N1 will be the next agent of a pandemic, but one of those two mechanisms, reassortment or direct adaptation, can occur. And it's clear for direct adaptation, the way that happens is the more people that are infected, the more passages the virus can have, the more likely that there could be a mutation or a series of mutations that render the virus more transmissible from person to person. And that's what needs to happen for a pandemic. This is just a very brief history of the H5N1. So the first cases in humans of the highly pathogenic form were first detected in China and Hong Kong in 18 cases that resulted in 6 deaths in Hong Kong. The previous year, there had been the virus detected in waterfall in southern China. The virus then was not detected for a few years and then reemerged in 2003 to 2005, basically causing outbreaks in poultry both in Asia, but also in Africa, the Middle East, and in Europe. From 2014 to 2016, there were H5 viruses with different types of neuraminidase. As you could see, H5N6 and H5N8 emerged. And then the clade 2.3.4b viruses started spreading a lot in 2018 and 2020. From 2021 to 2023, there's been a new strain of H5N1. Again, it's this 2344b strain from sort of called a Eurasian strain from a wild bird. Again, that's been very, very widespread now in Asia, Africa, Europe, and in the Middle East, and that's by the end of 2021. The virus was detected in wild birds initially in Canada and the United States in late 2021. In February of 2022, it started causing outbreaks in commercial poultry. So there have been rare, sporadic H5N1 cases in people. Again, no efficient person-to-person transmission. But in Canada, if you go to almost any poultry farm where people are raising chickens, they will have been affected by this highly pathogenic H5N1. And you could see here, this is just an example in one country, but in Canada you could see almost all the provinces have been affected, and the number of chickens that have been impacted is over 14 million. So extremely widespread and of a major concern. This is a slide from Health Canada showing that nearly 3,000 avian influenza strains in wild birds have been detected. This is a map of highly pathogenic H5N1 in the United States in wild birds, again, spread all over the United States. And more recently, it's spread to cattle. So there have been outbreaks in cattle in roughly half the states by now. So it's a major concern. And it's important to understand that the pathogenesis of highly pathogenic H5N1 is very different from seasonal influenza. To begin with, the receptors are different. Our seasonal influenza virus binds to an alpha-2,6 galactosase receptor, whereas the receptor is an alpha-2,3 in birds, in aquatic birds, and in chickens. And what that means is that our alpha-2,6 receptors are in the upper respiratory tree. So that causes person-to-person spread for seasonal influenza. However, we do have the alpha-2,3 receptors in the lower respiratory tree, in the trachea, in the bronchioles, in the alveoli, and in the conjunctiva, which is why conjunctivitis is an important clinical clue for H5N1 infection, as is severe lower respiratory tract infection. The other thing is in terms of pathogenesis, is the inflammatory response is much greater with highly pathogenic H5N1. The tropism beyond the upper airway is much broader as well. So you're more likely to see manifestations even outside of the lungs with this virus. This slide basically shows what's happening globally. It's an epidemic curve of H5N1 from 1997 to 2024 by country. And as you can see, most continents have been affected: Australia, North America, Europe, South Asia, Southeast Asia, Middle East, all have been affected by this virus. This slide summarizes the cases, again, over 900 cases from January 1997 to December 2024, showing the relatively high proportion of deaths. In fact, the case fatality rate is estimated to be about 49%. And of course, you need sero-epidemiologic studies to actually, really get a more precise figure. But even if it's lower than 49%, it's still a very severe infection that could cause a lot of complications, a lot of morbidity. This slide shows the spatial distribution of human cases from 2022 to 2024. Again, sort of widespread. This is of more recent cases in December 2024, again, cases from the United States. So in the same issue of the New England Journal from December of 2024, where they published that case report from British Columbia, they also published a report of 45 cases in the United States of people who had been exposed either to poultry or dairy cows. And one of the important clinical characteristics is the predominance of conjunctivitis. So 93% had conjunctivitis. Fever was about 50%. Interestingly, there were fewer respiratory symptoms, maybe 36% in all: cough, sore throat, shortness of breath. Systemic symptoms were still common: myalgia, headache. Fewer individuals reported fatigue, nausea, vomiting, or diarrhea. In terms of laboratory testing, the detection rate from RT-PCR from the conjunctiva were the highest. 88% were positive, less so from nasopharyngeal swabs, 33%, with a better detection rate using a combined naso-oropharyngeal swab. So in terms of prevention, which is most important, many countries have stockpiles, and these stockpiles included two types of adjuvanted vaccines. An adjuvant is a molecule that basically stimulates the immune system to produce a better antibody response, as well as mRNA vaccines. And there are no clinical randomized controlled trials here, but they're tested by immunogenicity. They produce antibodies. And one of the difficulty with just vaccination is that there's not enough vaccines to go around. For example, in Canada, it's estimated that anywhere from maybe 18 to 20% of the population would be covered with our stockpiles. The other difficulty is distribution. Distributing vaccine takes a lot of time, and there are certainly a lot of barriers. And there are many countries that don't have access to these vaccines. So there have been, as recent as March of 2025, there was a call out in the journal Science about the need to establish global networks to prepare for an H5N1 pandemic for efficient vaccination. So it's almost pretty clear that if there is an H5N1 pandemic, we will the best approach is to vaccinate, but that's going to take some time. So antivirals will play an important role as well. So these are a list of FDA approved antivirals for for influenza that could be used for H5N1 as well. And they include oseltamivir, peramivir, zanamivir, and those are neuraminidase inhibitors. Oseltamivir probably has the best safety record, dosed at 75 milligrams twice daily. It has to be dose adjusted. It's considered safe in pregnancy. It shouldn't be given within 2 weeks of a live attenuated influenza vaccine or 48 hours afterwards. Peramivir is given intravenously, single dose, 600 milligrams. Certainly are some hypersensitive side effects. It has to be renal adjusted. Same issue with live vaccine. There's no data for pregnancy. Zanamivir is inhaled twice daily. It can cause some respiratory symptoms, sore throat, cough, exacerbations of COPD. Again, no data for pregnancy, and you have to avoid the live virus. Baloxavir is a CAP endonuclease inhibitor. It's dosed at 40 milligrams if you're less than 80 kilograms or 80 kilograms if you're more. And it's relatively well tolerated with nausea and vomiting. There's no data on pregnancy. It's important to avoid polyvalent cations because they will interfere with the absorption of this oral drug. In terms of the literature for antivirals, there's pretty good evidence that antivirals will reduce symptoms duration in outpatients, maybe for 1 or 2 days. The area that's been the most debated has been the reduction of complications. And there have been 2 recent systematic reviews and a randomized controlled trial that help inform this. So this was a systematic review, a network meta-analysis of randomized controlled trials that looked at death, both for seasonal influenza and for zoonotic influenza. The problem is this was a very well done systematic review. The problem is the relative lack of data because the totality of the evidence is based on 1,400 participants and only 8 randomized controlled trials. So perhaps because of this, if you look at the data of oseltamivir versus control or peramivir or zanamivir, although the effect size, the relative risk is in the right direction of a 30 or 40% risk reduction, there's no significant effect. The confidence intervals are very, very wide, and the certainty, therefore, in the estimates is very low. So whether these actually reduce mortality is very uncertain, and it's even more uncertain for zoonotic influenza because there's no randomized controlled trials in this population. What they did is they based the baseline case on meta-analysis of death in zoonotic influenza, but they used the estimates of seasonal influenza to get an effect size. The data is a little bit better for hospitalization, where oseltamivir, peramivir, both of those had sort of a low certainty effect. So there was a reduction in the duration of hospital days by sort of 1 to 2 days, no real difference between oseltamivir and peramivir. Interestingly, there's more data for post-exposure prophylaxis, so that's basically when someone is at high risk of developing a complication. They've been exposed to influenza. There, this same group actually did a systematic review and network meta-analysis, but the data is better. There's more participants. It's based on about 30 randomized controlled trials and over 20,000 participants. And here you could see that, you know, it's probably pretty good for reducing symptomatic influenza. So this is for zanamivir, oseltamivir, baloxavir as well. So there is a moderate certainty evidence that this, you know, probably works. It might work as well for zoonotic influenza, where there's less evidence, though, for these agents. Again, there's no direct evidence for zoonotic influenza, and the estimates are based extrapolating from symptomatic influenza. Roughly about 2 weeks ago, there was a new study on baloxavir that was published in the New England Journal, and this was a randomized controlled trial. What they did here is they looked at index cases who had influenza, and they randomized their household. They basically randomized the index cases to getting baloxavir or placebo, and they looked at the effect at 5 days of transmission in household members, and they found about a 30% risk reduction. So they did RT-PCR systematically. When they looked at RT-PCR that was associated with clinical symptoms, there they didn't see any difference. It wasn't significant. So to wrap up, highly pathogenic H5N1 is a serious public health challenge. Whether it'll be the cause of the next pandemic is uncertain, but nevertheless, good preparation is essential. Thank you very much.